This program is brought to you by Emory University.
Good morning, everybody. Happy Friday. Welcome to Friday Fellows Conference. Our speaker this morning is Dr. Matthew T. Brown, who is one of our first-year fellows in the clinical track. Matthew is a native of Gwinnett County, if I recall, and Duke undergrad, Medical College of Georgia Medical School, and then here at Emory for his residency. And as you can see this morning, he's going to talk to us about aspirin, a very pertinent topic given some of the recent changes. So looking forward to hearing about what we should be doing with aspirin in our patients. Matthew.
All right, thanks so much, Dr. Williams. Good morning. I'm excited to talk about aspirin this morning. This is a question that really came from my Grady Continuity Clinic, working with Dr. Wenger. She posed it to me several times, and that's where my literature review was kind of motivated from. All right, but I think it's important to kind of take a step back and review aspirin and its lengthy history. So we'll do that to start. I don't have any disclosures, but I do want to let you know I have something called Pull Everywhere throughout this this session. It's an app that allows you to text in and kind of join in on the discussion throughout. So at a few different points, you'll see this pop up down at the bottom. But if you text 37607, or I'm sorry, if you text Matthew Brown 673 to 37607, you can join in on a few of the things that'll pop up throughout the lecture. No texting and driving though. All right, so just to get started here, my learning objectives for the session are going to be to go ahead and review the history of aspirin and learn how it took on such a role in cardiovascular health, to go ahead and understand the data driving some of the guideline updates that we've seen, mainly in prevention with a little touch on valves, and then to correlate these recommendations throughout, mainly with that Pull Everywhere, to hear from you and kind of discuss a few different clinical scenarios. All right, so we'll get started. Aspirin, an oldie but a goodie. The actual nomenclature is acetylsalicylic acid, or aspirin, which comes from this acetyl and then Spirea ulmaria, which is the certain tree that the specific salicin was isolated from, as some of the early pioneers went about sorting out the active ingredient. Now, the Egyptians knew about it from willow bark. It was isolated as salicin, and it was originally used as an analgesic. The New York Times called it the wonder drug that nobody understands in the 1960s. And it was actually the first drug that ever became available in tablet form by Bayer in the early 1900s. Now, proven use in cardiovascular disease, and actually has one of the first ever meta-analysis associated with its upbringing, and remains still one of the most commonly used drug worldwide. All right, so here's one of those first Pull Everywheres. We'll see how this goes. Just a little piece of trivia to start the morning off with. But this question is posed to the group, and it's asking, in what year was aspirin in its current form, so acetylsalicylic acid, first discovered? All right. Good. Someone was able to get into the poll. All right. Obviously, there's a wide range of dates here. All right. Well, I think majority of us got this right, but this is just to show each one of these dates is actually associated with some sort of significant event in the history of aspirin, and it takes us all the way back to 1934 BC. I do have a little timeline associated here to talk about aspirin's origins story. You see the chemical formula up here in the early initial salicin. Now, the ancient Egyptians and Sumerians were recorded to first talk about aspirin all the way back before Christ. And some of the earliest record that we have of this is actually on something called Ebers Papyrus, which was found, I believe, in the 1860s, purchased by a trader over in Cairo. He didn't know exactly what he had at the time, but he had these pieces of parchment that not only talked about aspirin and its use as a pain remedy, separated from the bark of willow trees, but also 159 other different herbal remedies. Now, thinking about more modern kind of aspirin, in the 1760s, a clergyman and fellow at the University of Oxford, Edward Stone, used the bark from the willow tree to actually treat fevers. That was kind of the first kind of recorded modern as opposed to BC. Now, in the early 1800s, there is a few different chemists that took interest in the active ingredient of willow bark and turned their efforts to really try to sort out what that was. In 1828, one of the first chemists isolated the active ingredient and found it to be salicin. You can see that above. And the next year, someone else replicated that data. And a decade down the line, someone performed the reaction to actually turn salicin into salicylate, which you can see is the next form over. Now, there was an American, I believe he was American, Charles Gerhardt, in 1852, that actually came out with acetylsalicylic acid, which is aspirin in its current form. Now, the reaction that he performed was too unstable to actually be mass produced or really used in meaningful quantities. So he talked about this in some publications, but was unable to kind of move forward from there. The idea and the motivating factor for him was there were talks of gastrointestinal issues with this salicylic acid, and they were searching for a more stable form or something to avoid those GI issues. So a little bit down the line in the 1870s, we had the first kind of clinical trials of aspirin, and it was used and aimed at rheumatism, and actually found to be kind of more or less a wonder drug. People's aches and pains and fevers were really cured with very high doses, and again with the adverse effect of GI issues. Now, in 1897, at the turn of the century, a German manufacturing company, actually a dye manufacturing company, Bayer at the time, had started a pharmaceutical industry. Now, this pharmaceutical portion of the industry was very interested in trying to replicate acetylsalicylic acid. So they formed this kind of part of the company that was headed by somebody named Dresser. Dresser was kind of removed from actually what was going on in the lab. There was someone that was more intimately involved. His name was Eckenbrew, and Eckenbrew hired this new grad named Hoffman, who's pictured here, who got to work right away, and within a year's time had created a reaction called the phenol reaction that actually took salicylic acid into acetylsalicylic acid. It was a very, at the time, much less arduous of a process as Gerhardt's 1850s attempt, and was able to be mass produced. This kind of went up the chain of command, and Eckenbrew was very excited about it. Dresser was actually less so, and initially put it down and said, this isn't going to work. We're not going to be able to use this. And as things played out, Eckenbrew put pressure, and Dresser eventually came around. Now, the situation is even more complicated than that, because Dresser ended up being the person that pushed forward, promoted all the clinical trials, and ended up making a small fortune off of aspirin, while Hoffman and Eckenbrew are remembered, but not remembered as well. So in 1904, they came out with a tablet form, and that's when clinical trials from there on out kind of started taking off. In the 1918s, they had the influenza pandemic, and there was widespread use of aspirin. There was talks of gastritis after the first gastroscope was invented and more commonly used. And then in the 1950s, we actually had some of the early pioneers in prevention work. Now there's two people. Paul Gibson was one of the first people to think about the link between aspirin and vascular diseases. There was some talk of aspirin increasing bleeding time. This was reported throughout the 1940s by dentists, actually, who would prescribe aspirin as a post-tonsillectomy analgesic. Now, Dr. Craven, who is a family medicine doctor out in Los Angeles, actually would prescribe aspirin very commonly. He would infuse it in a chewing gum and give it to his patients, his pregnant patients that just underwent childbirth, and had good effects. Now, he took that one step forward to also start looking at prescribing aspirin for the everyday person. And he described in several kind of publications, and this is one of them, his experiences with aspirin and non-specific prophylaxis of coronary thrombosis. He didn't have any hard data, but he prescribed it to over 8,000 patients, and he picked them as males aged 45 to 65 who were overweight, sedentary lifestyle. And he was able to say at the end of it that he didn't see any signs of stroke. He didn't see any signs of MI in those patients that he had it on. Now, his work was questioned when he himself ended up dying of a heart attack later in the 1950s, and was largely kind of overlooked. So, all right, that was a lot, and there is more, and this is more of the exciting time period for aspirin. They were able to isolate it, they were able to synthesize it, come up with the aspirin in its purest form, but still they didn't know exactly what it was and how it worked. So the turn of the century, turn of the 1960s and early 1970s, more people were doing work with platelets. The platelets were found back in the 1860s, but someone, I believe Dr. Weiss, had come up with an aggregometry, which allowed them to actually see platelets and look at platelet reactions. So in the late 1960s, aspirin was truly found to inhibit platelet function, which was kind of hypothesized early on, back in the 1940s, as people were working with warfarin, and they noticed that aspirin, similar to warfarin, would inhibit or prolong the bleeding time. Now, in the early 1970s, someone named Dr. Vane, who's pictured here for an important reason, actually found aspirin to inhibit prostaglandin synthesis. He was working with rabbits, and he had a specific technique where he was able to sort out different cytokines involved in blood flow. And he and some other people in the lab would add things in and take things out. And one of the things that they isolated was called rabbit aortic circulating factor. Now, they were able to kind of pin down what rabbit aorta circulating factor was, and they identified it as a prostacyclin. But still, for a few years, it was still rather unclear exactly how that was, what specifically was going on. And in 1975, and another chemist, Dr. Samuelson, actually isolated out that specific prostacyclin to be a thromboxane A2, which he then went on to learn and kind of reveal the overall underlying mechanism of aspirin by inhibiting the COX-1 and doing so irreversibly for a period of time. Now, let's see. In 1982, two of those gentlemen, Dr. Samuelson and Dr. Vane, joined by Dr. Bergstrom, who actually had identified prostacyclins at an earlier time. They all three were recognized with a Nobel Prize in Physiology and Medicine for their discovery. And that's after the mechanism was isolated, and there was this true link to platelet inhibition, is when a lot of the efforts in aspirin moved away from the analgesic indications and started looking at the cardiovascular indications. So let's see, I have the mechanism of action here as sorted out by the Nobel Prize winners. We have the COX-1 homodimer, and I haven't done any of this from biochemistry, but we have, thinking about aspirin up here in its current form, it has this acetyl group, and the acetyl group actually comes in and blocks irreversibly the COX-1 inhibition, or COX-1, and that ends up feeding downstream and preventing thromboxane A2 from forming, which was, as you remember, rabbit aorta contracting substance or circulating factor. All right, now jumping back in to kind of the clinical ramifications of this discovery. There's really two trials that started looking at thrombosis, and one that was actually pretty large, carried out in the New South Wales in 1970s, looked at the secondary prevention of MI. So they looked at over 5,000 patients that came in with a myocardial infarction of different degrees, and they prescribed them aspirin, 300 milligrams, once daily to be taken thereafter, and they followed them. And you just see kind of this very, very small diagram. But aspirin was shown to actually move away from the placebo curve, and this kind of drummed up some excitement. So there were several other randomized controlled trials, but one of the landmarks is this 1988 ISIS-2 trial. So we'll pop in and we'll kind of look at these really two trials that happened within 5 years of each other. So I'll focus on the VA cooperative study first. This happened across 12 different VAs. It included 1,200 men, and they were actually given 625 milligrams of, aspirin 324 in 600 patients, and then the placebo was an equal amount in 600. And they ended up finding that death or acute myocardial infarction rates were significantly improved taking aspirin. This was a 12-week study period, and they looked at patients with unstable angina. So not totally the MI, but a little bit of angina that was bringing these patients in throughout the VAs. Now, if we can turn our attention to the second international study of infarct survival, or ISIS-2. The first one had just looked at something called streptokinase, which is kind of a systemic thrombolytic. It's different than the TPA that we use nowadays. It doesn't have the specificity attached to it. It's more of a kind of wild type or systemic thrombolytic. But they looked at 1,700 acute MI patients in 417 hospitals across Europe, and they caught them within 24 hours of chest pain onset. So people are coming in, and they have this protocol that randomized each one of the participants to one of four things. Either an IV bolus, 1.5 million units of IV streptokinase, and then in conjunction with 30 days of aspirin at a 160 milligram dose, or just that streptokinase bolus, or just 30 days of aspirin. And this is all versus placebo, either IV infusions or tabs. I believe everybody got them, just to keep it similar. And what they found was very impressive. So this is a chart looking at the cumulative vascular mortality over the first month. And if you see the placebo infusion, it climbs up to a mortality rate of 13.2%, whereas just aspirin and streptokinase alone bring that rate and separate the curves at a very similar rate, putting the mortality in around like 10.5%. Now, what was particularly impressive was the combination of the two things, streptokinase and aspirin, had a much greater reduction, from 13.2% all the way to 8%, and very different curves. So this was one of the first studies that really put to the test aspirin use in the setting of acute MI. Now, the absolute mortality reduction was reported at 2.4 per 100 people, and that came out to a number needed to treat of 42. There were bleeding complications that were much more commonly seen in the streptokinase cohort. That kind of limited streptokinase from going any further, but still opened the door for aspirin. Now, moving along, ISIS-2, the VA cooperative study, both kind of spurred much more investigation into using aspirin and using antiplatelet therapy mainly for MI and for coronary thrombosis. So it's for this group, which they call themselves the collaborative, the Antiplatelet Trialists Collaboration. Their goal was to determine the effects of prolonged antiplatelet therapy. And this group looked at 145 randomized controlled trials that mainly looked at antiplatelet use versus placebo. And there was several different types of antiplatelets. It wasn't just aspirin, but aspirin was the majority. And then 29 randomized controlled trials that actually looked and compared different antiplatelet agents. So this group, in their first publication, included studies available by March 1990. So still very early data. They published this in January 1994. And they were able to separate out, because they had such a big database of trials, 70,000 high-risk patients, which they included as acute MI, prior MI, people that had TIAs or strokes, and then a group of other patients that they described as chronic CAD patients, AFib, valvular heart disease, peripheral arterial disease, and unstable angina. It's really kind of high-risk group. And what would form the basis of patients with established atherosclerotic cardiovascular disease. Now, they also looked at a group of 30,000 patients that they said were low risk. And this kind of became a primary prevention correlate. Some of the antiplatelet regimens included aspirin or aspirin plus dipyrimidine and then sulfapyrimidine. The majority were aspirin at various doses. So the overall results were reductions in vascular events by about a quarter in each high-risk group. There is a combined 33% reduction in non-fatal MI and stroke, and also combined 17% reduction in vascular death, which is very impressive. There's no evidence that higher doses of aspirin were more effective. And then among the low-risk group, the absolute relative risk ratio was lower and not significant, besides non-fatal MI, which is very interesting, because I think as we get on later in the presentation, you'll see that holds true. All right, so we're looking at we're looking at the year of the first vascular event. And this table is it's hard to follow. Each one of these groups is one of those high-risk populations, either acute MI, and you can see there's actually 2 lines associated with each one of these groups. Acute MI had kind of some impressive reduction, but is all kind of over. Unstable angina, very similar. You see a reduction there. And then with high-risk populations, you also see a reduction in years to first vascular event. Now, the low risk kind of floats off into space, and there's not much difference there. Looking at kind of the odds ratio for overall MI, stroke, vascular death, you see that antiplatelet therapy was better more often than not, and mostly in the high risk correlations or patient populations as opposed to the low risk. Now, this holds true for each one of those kind of high risk populations. Non-fatal MI is effectively reduced. Non-fatal stroke was found to be reduced as well, except in the low risk. Vascular death, and everything's on the left side of the screen. And most impressively, the most impressive thing I took away from this study that you don't often see in studies nowadays is death from any cause. Not only vascular death, but death from any cause was significantly reduced with the use of antiplatelet therapy. And after these prior MIs, acute MIs, prior strokes. So they also went on in this study to look at different aspirin doses. You can see 500 milligrams of 1500, a kind of medium dose of 160 to 325, and then low dose. Now, there's varying different number of trials for each one of these, but they were able to show that there really wasn't much of a change. You saw a significant reduction throughout each one of the aspirin doses. And compared to other aspirin regimens, some not including aspirin at all, just other antiplatelet agents, it seems to be almost a class effect. You do see improvement throughout. Now, their final clinical implications were kind of summarized here, and they're more or less what we've gone over, and you've seen the data behind. But antiplatelet therapy protects a wider range of patients at high risk of occlusive vascular disease and is currently treated routinely. There's no clear evidence that antiplatelet therapy is indicated for routine use in primary prevention of subjects. They even went out to say that based on their low risk data cohort. And then medium dose aspirin, anywhere from 75 to 325, is most widely tested. And no other regimen appeared more effective. So this collaborative went on to provide a 2002 update. And I know we're kind of marching through time right now, still 20 years out. But I think it's so important to go through these early studies because they set up the guidelines, they set up what we know today. And still, as evidenced by these studies, do have some very strong data behind them. Now, this collaborative meta-analysis looked at antiplatelet therapy for prevention of death, myocardial infarction, and stroke. It was largely the same sort of setup as the last or the first, but just included much more randomized controlled trials. In the last cohort, published in 1994, they had about 160 trials, and now they're up to 287. They looked at over 135,000 patients in antiplatelet versus control, and then 77,000 in just aspirin as compared to other antiplatelets. They found some kind of wide ranging results that aspirin and other antiplatelets are protective in the most high-risk patient population. And low-dose aspirin was effective for long-term use. They even said you may need a loading dose in the acute setting, which is something that we do still today. And then adding a second platelet agent was something that they were interested in by the end of the study. Very similar charts to the last one, looking at antiplatelet therapy as opposed to kind of placebo here, and then looking at the odds ratios and for number of vascular events, you can tell that it favors antiplatelet therapy, and running down the high risk patient populations, or and even here they separate out coronary disease and they look at each different type, whether it's unstable angina, people undergoing bypass or angioplasty, and then even in the stable population. Interestingly, heart failure here, there's only 2 studies, but it does not show that association. And looking at other indications, it is somewhat telling. All right. Now, again, they go ahead and they compare aspirin in different doses to different antiplatelet therapies. Now, this is the first time that we're seeing these markers kind of hover around 1, and that is because they're comparing aspirin to itself or other antiplatelets to aspirin. In this top group, they're looking at aspirin in high dose to low dose, and then a very low dose in the next one, and there's no difference there. Looking at aspirin as it compared to several different other antiplatelets on the market at that time, including clopidogrel, you can see there's not much difference, but they do kind of cite clopidogrel as a possibility. I think they ended up saying there's like a 12% risk modification there. And what they also drew attention to was the use of aspirin and an intravenous glycoprotein inhibitor in the acute setting. They actually saw the combination of those 2 things actually added to the treatment effect. Now, I like this kind of overall summary here. What this study adds: antiplatelet therapy protects against vascular events among patients with stable angina, claudication, AFib, can be started promptly during the acute setting, and daily aspirin doses of 75 to 150 seem to be just as effective as higher doses. They even go on to say clopidogrel is an appropriate alternative to people with a contraindication to aspirin, and they kind of spurred some additional investigation into glycoprotein use, especially in the acute setting. So, all right, we've gone through some of the key studies, and now I want to kind of shift our thoughts, shift the focus, and look at the guidelines. So if we go back to our poll everywhere that was set up, this is more of you can just type in how you would manage this patient, and hopefully you'll be able to just type anything. But there's a certain patient, he's 66, he's got some risk factors, hypertension, hyperlipidemia, and he recently had a stent placed about a year ago. And he's presenting a follow-up, he's doing fine, he's stable, he's taking his DAPT, which involves ticagrelor, aspirin, and he's being managed with a statin as well as toprol. So he is wondering if he can stop any of these. So if you have any management recommendations, you can type them into the chat now. And if not, you can move on and learn how we would tackle this. All right, so looking at the secondary prevention guidelines for aspirin, I want to start with secondary because I think they're a little bit more clear-cut. And they reference a lot of the data that we just went through, the ISIS trial, and the VA cooperative, and then the collaborative data published by the anti-thrombotic groups. Aspirin is truly a class 1 level A recommendation to be used in all patients with coronary disease. And the only alternative, or another alternative, is clopidogrel, which we saw came from that anti-thrombotic study. P2Y12 receptor antagonist in combination with aspirin is thought to work for ACS and PCI. And patients undergoing coronary bypass grafting should also be started within 6 hours to reduce the rates of saphenous vein graft closure. Dosing regimens from anywhere from 100 to 325 appear to be effective for that. Now, the rest of these, we even have recommendations for peripheral arterial disease, and then how to go about antiplatelet therapy to treat people with kind of chronic atherosclerosis too. Or this is all established atherosclerotic cardiovascular disease. There are class 2A and 2B recommendations. And I feel like this is a situation that comes up time and time again, and especially in the inpatient setting. If the risk or morbidity from bleeding outweighs the anticipated benefit afforded by this type of therapy after stent implantation, earlier discontinuation is reasonable. And they know that there's more serious cardiovascular events with people with drug-eluting stents than those with bare metal. Now, I want to look at some of the recent studies that have been performed in secondary prevention, specifically looking at this particular study, which has been dubbed the adaptable study, that took on a more or less a new role in research, looking specifically at, is there one dose that's better than the other? It was a different type of study because they recruited 15,000 patients out of a patient collaborative database, where they across several different hospital systems, I believe in the 40s, patients were part of this network, and they sent out surveys and didn't ask the patients to namely change how they take aspirin. All of them already had established cardiovascular disease for some reason or another, whether it be prior CAD or stenting. And they looked at people taking aspirin 81 milligrams versus those taking 325. It was almost a clear split, 7,500 in each group. And they tracked that hospitalization for either MI or stroke, and they didn't see any significant difference between the two different doses. What they also reported was no significant difference between the major bleeding rates. So their overall conclusion was, effectiveness and safety outcomes didn't differ significantly for those with established cardiovascular disease taking aspirin. And they said aspirin 81 appeared to be just as effective as 325. Now, one of the questions, and the question that I posed to the poll everywhere is, there's been some thoughts about aspirin as the chronic maintenance therapy, mainly post-PCI. And there's been some recent work reported that looks just at that. Is there a role for other P2Y12 inhibitors as monotherapy for this chronic maintenance therapy, as opposed to aspirin? And this particular study was a meta-analysis that looked at 9 different studies for a variety of indications where they were using aspirin, and then we're combining it with P2Y12 inhibitor. And that varied. Taclopidine was in there, clopidogrel, and then ticagrelor in more recent studies. Now, they went ahead and they compared the two, or they looked at the rates. They looked at for all-cause death, they looked at vascular death, stroke, and myocardial infarction, and compared, because each one of these studies took that P2Y12 inhibitor and maintained it as the chronic maintenance therapy as opposed to continuing aspirin. And they did not find any significant differences across these indicators. Now, what they did report, or kind of stuck in a supplemental table, was that there was some risk of bleeding, and the gastrointestinal risk of mainly bleeding actually did favor P2Y12 inhibitors, as aspirin was found to cause more GI bleeding events at a significant rate. All right, now this particular study pertains to the question that I posed at the beginning of the secondary prevention exploration. This is a brand new study. It was published, dubbed Host Exam, in 2021, published in The Lancet. And it was a group of 37 sites throughout South Korea that compared Plavix with aspirin as chronic maintenance therapy. It was prospective, randomized, and notably open label. They looked at a group between 2014 and 2018. Anybody that came in and underwent any sort of PCI was randomized to either receive aspirin 100 milligrams or Plavix 75 milligrams as their chronic maintenance therapy. These are patients that had tolerated DAPT, the combination of those two, for at least 6 months, and in some cases 18 months. And they looked at, as their primary composite endpoint, all-cause death, non-fatal MI, stroke, ACS, readmissions. And what you can see here is that their primary composite death and their thrombotic composite endpoints were both met by using Plavix and in a significant fashion. The hazard ratio favored clopidogrel over aspirin. Looking at bleeding, it was the same. These are, and I'll draw your attention to major bleeding events, which did appear to be reduced by Plavix as well. Some things that were questionable were looking at the actual mortality data, all-cause death, cardiac death, non-cardiac death, all seem to have higher events in the Plavix group. They're all non-significant, but this is something that they commented on in this study as well. Stroke was also particularly significant and did favor Plavix. Now, let's see. Okay. The questions that I had from this study really have to do with, its generalizability to the US population, especially with knowing that Plavix, about 30% of people are non-responders. And I would wonder how this would play out in a randomized control trial here, and whether or not that we would come up with similar findings. But to date, it is one of the largest that specifically compares this question of post-PCI chronic maintenance therapy. So I pose another question here about which organizational body do you turn to for primary prevention guidelines, as there have been considerable updates and considerable amount of guideline recommenders. And I just kind of set up a track over time of what was going on with primary prevention. And I try to kind of consolidate all the recommendations from all the different organizations, the earliest of which came from the American Heart Association, 1997, that actually delivered 1997 guidelines and didn't comment on aspirin. Now, after the antithrombotic trials were published, they updated guidelines in 2002 and went ahead and said aspirin and low dose in persons with high risk. And that is very specific to those antithrombotic trials. They found that benefit in high risk or established ASCVD, not so much in the low risk. They added a risk stratification, said aspirin in low dose form was recommended. In 2006, the American Diabetes Association came out with something similar, and they put an age criteria on this. They said age 40 with diabetes and high cardiovascular risk, we do recommend it. And then the United States Preventive Services Task Force in 2009 came out with data, or came out with recommendations, and different recommendations for men between certain ages and women between certain ages. And they cited different things as well. For men, they're recommending aspirin to reduce the myocardial infarction. In women, they were talking about the benefit of ischemic strokes. Now, each one of these cited risk and benefits had to be kind of monitored for idea of gastrointestinal hemorrhage. Now, this data and these recommendations were largely based off of these two studies. One, the Physicians' Health Study, which was published in New England Journal of Medicine and all the way back in 1989. The other, Women's Health Study, again in New England Journal of Medicine in 2005. Both of these studies actually sent out mail, either to physicians in this cohort or women in the healthcare setting, in this study. And they sent almost 500,000 letters out, attracted a kind of patient population, and narrowed it down from there. But that's where they get these huge or large cohorts of 22,000 for physician's health study and almost 40,000 in the women's health study. The interventions were the same, or I'm sorry, they were slightly different, but they were dosed every other day as opposed to daily. In the physician's health study, they use aspirin 325, whereas women's, they use 100 milligrams a day. And the results actually kind of mirror those USPSTF recommendations. In the physician's health study, they talk about a relative 44% relative risk reduction in MI. There was no big difference in all-cause or cardiovascular deaths, and they did have borderline significance for hemorrhagic stroke, GI ulcer formation at a relative risk rate of 1.22, and then significant bleeding and transfusion needs with the use of aspirin just every other day. In women's health study, looked at gender-specific population, and they followed them for over 10 years, and they didn't find there was a non-significant risk reduction in MACE, but their main finding was this 17% risk reduction of stroke, and that was largely driven by ischemic strokes, although they did find significant GI bleeding, and no overall effect on MIs or cardiovascular death. So that brings us, that kind of shows where those 2009 recommendations came from. But now we've updated again with the ACC/AHA coming out with 2019 recommendations, and the ADA as well, updating in 2020, both kind of dialing it back on aspirin and saying, low dose aspirin might be considered for a specific age range, 40 to 70 for the ACC/AHA. And the ADA, they even dial it back further and say, with diabetes between 50 and 70, or increased risk for ACVD. So where are these recommendations coming from? I want to just quickly review 2 studies here. The aspirin and reducing events in the elderly. Over 19,000 patients were included, and they were healthy. No cardiovascular disease, no dementia or debilitating physical disabilities, and they were aged over 65 in Blacks and Hispanics, and then 70 in US and Australia population. The intervention was aspirin 100 milligrams daily with a 5-year follow-up, and they found no difference in the disability-free survival, whether taking aspirin or not. But they did find higher major hemorrhage rates in their secondary endpoints and higher all-cause mortality. So just to show you curves, this was the cumulative incidence of cardiovascular disease with a comparison between the two. And this is a big group, 20,000 patients, more or less split down the middle. You don't see much change in those curves. But here, when looking at major hemorrhage, you see aspirin has a greater cumulative incidence, a greater hazard ratio, and then particularly death related to cancer, which was the driving force behind this, this worse all-cause mortality using aspirin. You see those curves separate as well. The ASCEND trial was looking at cardiovascular events in diabetes. They attracted 15,000 patients for a mean follow-up of 7 years, and they looked at, similar to aspirin, 100 milligrams of aspirin a day, and they found lower rates of serious vascular events with aspirin. So that was good. They defined these events as MI, TA, stroke, and cardiovascular death. So this is a composite of those things. And you see a relative risk reduction of 0.88, and the primary safety outcomes that showed higher rates of major bleeding with aspirin, most often GI or some other extracranial. So we're not talking intracranial head bleeds, but gastrointestinal bleeding was found to be higher, and there is no difference in incidental GI tract cancer. So I thought this picture from the study was very appropriate. As you see, vascular outcomes are proved better in aspirin, but looking at placebo and bleeding definitely outweighs aspirin there. So it was really these 2 studies in there was a third one that we'll briefly talk about that led to these USPSTF recommendations that are really relatively recent, October 2021, and awaiting a final update. But they even take a further step back from aspirin, and they say patients with trying to separate out a high-risk population, greater than 10-year cardiovascular disease risk of greater than 10%, age 40 to 59, as opposed to the anybody greater than 60 should be considering using aspirin therapy as a role of primary prevention. Now, putting it all together, I found this wonderful study by colleagues here at Emory University that looked at several of these studies, and then even other studies in the peripheral arterial disease space that looked at aspirin use in primary prevention. And I thought they did a wonderful job of really making the points and comparing the data between these 10 great randomized control trials. And we already talked about Ascend and Aspri, but Arrive was also done in 2018. And while they were looking for a moderate risk group of cardiovascular disease, they really ended up only capturing a low risk group. And as you can see, there was really no significance in the rates of non-fatal MI, non-fatal stroke, cardiovascular mortality, or all-cause mortality, but they did find problems and issues with GI bleeding, as had been reported in prior studies. So I thought our colleagues did a wonderful job of putting it all together and really putting it to the clinicians to say, for that certain age group where there is some proven benefit or considered benefit, we need to be better about risk stratification. And how do we do that? We have that shared discussion with patients. We look at some of the biomarkers that we typically follow. We consider kind of high risk family history and compare that with bleeding risk, and have more of a discussion with the patient to figure out which is more important to them. And if there's any still concern or pause, they talked about in this article, incorporating the coronary calcium score as kind of another form of risk stratification, and looking at the MESA risk calculators too. So I don't think I'll have time to talk about valvular heart disease, but the down low from this is that for stable valvular heart disease, there is no indication for aspirin in the most recent guidelines. Talking about mechanical valves and bioprosthetic valves, that's where aspirin first appears in the guidelines, and it's all moderate 2A data that kind of drives any of the recommendations, or even weak class 2B studies. So final thoughts before closing out. For secondary prevention, it does seem, for primary prevention, keen assessment of cardiovascular risk between patients 40 and 59 needs to be carried out. And it seems that way back when I first started talking about the timeline, Dr. Cravens proposed in the 1950s what may be most applicable, and just didn't know it and was overlooked. But now we're coming back around to that. Shared decision making is necessary. Patients with established atherosclerotic disease should be on an antiplatelet, and there's more evolving data on the long-term safety of P2Y12 as a maintenance therapy as opposed to aspirin. And there's really minimal use of aspirin in valvular heart disease outside of surgical or mechanical or bioprosthetic valves. These are select references, and I just want to say thanks so much to Dr. Wenger and Dr. Salek, our chief fellow, for helping me put this together and kind of thinking about the thought process here. So I'll open for questions and comments. I know that was a whirlwind, and we're coming up on time.
Thanks. Go ahead, Stanley.
Yeah, thanks. Matt, through your readings and studies, how about the patients who are already on, our new oral anticoagulants? and the use of, is there any use of aspirin if they're already on those?
And I presume you mean for like stable vascular disease, like chronic
Yeah.
coronary disease. Yeah.
Yeah. In other words, they are, well, let's put it this way. Let's say they're atrial fib patients. They're on their anticoagulation. Has, should we think about combination with aspirin or clopidogrel with any of those patients?
Um, yeah, this is a very common thing. It's something that we deal with inpatient very frequently when someone comes in with new onset AFib. They already have established ASCVD. They're already on aspirin statin. They may have had stents in the past, and this is where I kind of defaulted to the guidelines. I didn't go really looking at the evidence that was out there, but if the 2011 guidelines do recommend continuing that aspirin for the atherosclerotic risk, and then just as long as they're able to tolerate it on top of that anticoagulation agent, whether it be DOAC or warfarin. So that is the guideline recommendation. Whether or not that is going to worsen bleeding outcomes, I think there's probably some data out there on that, and that's where shared decision making is going to come in.
If I could just comment real quick, there's some updated ESC guidelines that recommend, in general, that if you have coronary disease and atrial fibrillation, that you should only use anticoagulation without antiplatelet therapy. And there's a couple registries that suggest only harm when aspirin is added to anticoagulation. And there's 2 randomized trials, one of them, which is I think probably large enough with NOACs, that suggest aspirin only leads to harm. And so I don't think the American guidelines have been updated, but the Europeans have recommended against using aspirin.
And that's obviously like for long-term maintenance, not in the first 6 to 12 months after.
Right. Yeah. Just if you're doing secondary prevention for coronary disease and treatment for with anticoagulation, that you just need one agent, and that's usually the anticoagulant. That aspirin only adds harm.
Matthew, my question, and you sort of touched on this a little bit, particularly now that clopidogrel is generic and not as expensive, given that some of its data long-term in terms of bleeding was superior to aspirin, should we consider this our go-to long-term secondary prevention antiplatelet drug potentially for chronic, coronary disease or vascular disease patients?
Yeah, this is a question that I had myself. So I was very happy to be able to find this study, this host exam randomized clinical trial. I think while its data is very promising in terms of clopidogrel and really kind of reducing the amount of major bleeding and meeting some of these composite endpoints, being safe and effective, and kind of not having high amounts of readmission. I do think in the US population, I'm not sure that this study is entirely generalizable. I know, and I would love to see some additional studies come out, performed here, so that we could be able to better understand the risk. And the reason that I have so much pause is that I know 30% of the population here does have loss of function and are platelet or Plavix non-responders. This is something that they touched on with this study, and they actually quoted higher rates of that loss of function gene among the patient population. They quoted 50, 60%, but they also talked about there's a little bit of a paradox there that they've seen with their prior studies, where even if they're Plavix non-responders, they seem to be doing okay. So that is the only reason that I would have pause before.
Dr. Wenger has her hand up.
I think that here is probably the only place where I would recommend testing. That if you're in the situation where you say, well, now am I going to do dual therapy or am I going to put patients on clopidogrel alone? This is not an ACS setting. You have the time to do testing. And if you have a patient who is non-responsive to clopidogrel, then you try another P2Y12 agent. Again, this is reason, not clinical trial, but there are some people that are starting trials comparing different P2Y12 agents for long-term therapy.
Thank you. All right, well, we're sort of past our time, so I think we should probably wrap up at this point. So Matthew, thank you. Very good review of a lot of data and history and pharmacokinetics and biochemistry. So thank you for that. And thank you everyone for tuning in, and we'll see everybody next Friday.
The preceding program is copyrighted by Emory University.